What are the potential poor prognostic indicators in alopecia areata? The first and the most important two factors are the early presentation, the younger presentation, so childhood onset of alopecia areata, especially those presenting at less than 6 years of age, they have more chance of developing into a more progressive disease, extensive disease, and also chronic disease. Also, the second, and it is the most important negative prognostic indicator actually, which is the severity of the disease at the time of presentation. Other poor prognostic factors are duration of the active disease, with alopecia areata persist beyond 5 years, have a potential of around 2% of hair regrowth, and if it persists more than 10 years, it could be irreversible. However, this cannot contraindicate or deprive the patient of trial of therapy. Other poor prognostic factor, alopecia areata phenotypes, especially the ophisis pattern, involvement of the non-scalp hair with eyelashes, eyebrows, and beard, nail involvement, most commonly nail pitting, and less commonly trichonychia, may suggest an increased risk of developing more severe alopecia areata and worsen the prognosis overall. The associated atopic condition, also considered as a poor prognostic factor, trisomy 21, this syndrome associated with increased prevalence of alopecia areata, around 10%, and the severity in this population actually is estimated to be 40% of these patients will go into alopecia totalis or universalis at any given time. And what makes this population more challenging, the overall health condition, the associated comorbidities will leave you with very limited options of treatment. Alopecia areata lesions may be induced or influenced by systemic factors like hormones, immunological like pro-cytokines. Example of these systemic association include diabetes, peptic ulcer, hypertension, and hormonal disease, Graves and myxedema. Association with autoimmune disorders like vitiligo, pernicious anemia, and other autoimmune disorders suggest a genetic association with a common pathogenesis. However, these associations were linked in the past with poor prognosis in some studies, but they were not subsequently confirmed. Family history also was thought as a poor prognostic factor, but it's not been proven. Other prognostic factors, we talked about the clinical poor prognostic factor, but we have other prognostic factors that might be helpful, like trichoscopic markers, can be useful in predicting the course and to assist the response to treatment. So black dots, yellow dots, and short vellus hair may correlate with disease severity. Tapering hair, broken hair, and hair powder may correlate with disease activity. Yellow dots in hair-bearing area of the non-involved scalp area might indicate disease progression at any time. The other part of my topic is the treatment in special situation. We all know that alopecia areata in children is common, and about 60% of patients with alopecia areata will present in the first 2 decades of life. So it's very important to highlight the treatment options for children. The first and the mainstay treatment is topical steroid. Go for medium and high potency like mometasone to clobetasol. And if there is a contraindication or failure of a treatment, you can go to another option of the topical treatment like anthralin. Anthralin actually has the advantage of its lack of systemic adverse events, so it can be a good option in children. Contact immunotherapy, but of course not in the active disease. Minoxidil, but keep in mind when you use minoxidil in children, they are more prone to hypertrichosis, even if they are not responding to the treatment. Topical calcineurin inhibitor, even they are used commonly in the clinic, but the evidence for their use is inconsistent so far. The second line treatment in children is the combination of 2 or all the 3 of these therapeutic options that were discussed in the first line. Regarding the systemic therapy, it's considered the third-line management in children, but there is no data confirming that systemic therapy will reduce the risk of subsequent development to alopecia totalis or universalis, and there is no consensus on the use of the systemic therapy in children, so a decision can be taken by an experienced dermatologist on case-by-case basis, taking into consideration the risk and benefit assessment. And what about intralesional steroid in children? The child in this photo is smiling, but this is not the case in the real life. Intralesional steroid are not a feasible option in children because it's very painful and it needs sedation. And all we know that we cannot treat in one session, we need multiple sessions, and is not a feasible option to use it in children. When it comes to the alopecia areata and the facial hair, actually we face it very commonly nowadays. The patient only present with only beard area alopecia areata. What is the treatment of choice here is topical or intralesional steroid. But when you go for intralesional triamcinolone, don't go with higher concentration. The maximum concentration you can use in a beard area is 2.5 milligram per ml. And you can go to other options like an adjuvant treatment, topical minoxidil, and the alternative or second line treatment, anthralin. There is no consensus on the usage of calcineurin inhibitors in alopecia areata and the beard. Also, we know most of the clinicians, they use it frequently in the clinic. When it comes to alopecia areata and the eyelashes, the treatment of choice is the analog of prostaglandin, F2 alpha, latanoprost, bimatoprost, in a solution used once daily. However, you have to use the treatment for a minimum of 12 months to be able to assess the response to treatment. Also, keep in mind the risk of eyelid hyperpigmentation and the darkening of the iris. When it comes to eyebrows, treatment option include topical corticosteroid of medium potency or intralesional triamcinolone, of course, not higher than 2.5 milligram per ml. And when you choose the topical treatment, go for a cream better than solution to decrease the risk of leakage into the eye. Other options include bimatoprost, topical minoxidil, and always when you prescribe any topical medication at any time, always advise the patient to avoid getting the medicine into their eyes. After failure of topical or intralesional modalities for both eyebrows or eyelashes, systemic treatment may be considered. Take-home messages include prognosis in your thorough consultation for alopecia areata. So your consultation in the first time should be detailed and thorough. Poor prognosis does not deprive the patient from a trial of therapy. In children, take into account the life stage and the degree of development when considering systemic treatment for alopecia areata, especially with most of these treatments affecting the growth and the immune status of the patient. Caution should be taken when using intralesional corticosteroid in facial alopecia areata. With that, I conclude, and thank you.